Hi, welcome to another installment of Pathology Scuba. I am Dr. Pratima Singh. I am very happy to be back, and today I'm going to talk about one of my favorite subjects, which is going viral. As always with Pathology Scuba, what we'll talk about today is ideally intended for medical student education. If you are not possessed of some biomedical education coming in, this might be a little bit advanced. Conversely, if you are a practicing physician, this might not be discussed in enough detail for your purposes. But what we'll do today is we will try to talk about viral infections, and we'll talk about them both from the standpoint of classic scenarios that you might see those viral infections and tie them to the histomorphology that would help you recognize the particular virus responsible for that infection. So to start our discussion, we're not going to show a virus, we're going to show a bacteria. And there's a reason for this, bear with me. So what this image shows is a gram stain of a urine sample from a patient with a urinary tract infection. You might recognize this cell right here because of its segmented nucleus. That's a neutrophil. Here you can see the scattered rod-shaped bacteria, which are staining in a gram-negative way. And this is, of course, E. coli. E. coli being the most noted pathogen, the most prevalent pathogen for urinary tract infections. So why do I start with E. coli? Take a look at this image. At the bottom, you see E. coli, and this is maybe a third, maybe half of what the entire bacterium would look like. And in comparison, look at all these viruses. They're quite small. So you can imagine that if bacteria are this small, how small are viruses? So that's the first takeaway. Viruses are extremely small. So let's talk about another quality of viruses, which is that they are obligate intracellular pathogens. Take a look at this image and just refresh your memory on the fact that these viruses need access to our cells and our nucleus to have a factory by which they can replicate and assemble and then be released to be new virions, right? So we kind of know a little bit about this from microbiology, hopefully. So knowing that you have very small viruses that could be hard to see by themselves, but tying that to the fact that you have to have intracellular access to kind of create a little virus factory takes us to how we are going to recognize those viruses, which is viral inclusions. Using specific properties of viral inclusions, you can identify a whole host of viruses. And this is a list of all the different viruses that we're going to be talking about today. And so hopefully by the time this session is over, you'll feel a little bit more comfortable with what you're looking at. So let's start off with herpes simplex virus. One thing that I wanted to demonstrate through use of electron microscopy is how much space occupation herpes has within the nucleus. Again, we don't use electron microscopy for routine analysis for virus, right? But this is a nice image because what it's showing you are these viral capsids within the nucleus. And what's essentially occurring is there's so much viral activity within the nucleus, it's actually pushing the normal nuclear chromatin aside and causing the nucleus to become more optically clear inside. And that is going to translate to what we would see on pathology. So as that chromatin within the nucleus gets pushed aside, the center of the nucleus becomes, like I said, lighter, more optically clear, and what's called glassy. So this is a pap smear. This was a pap smear from a patient who had herpes simplex virus, type 2, and you can see that these nuclei do have that chromatin kind of pushed aside so that the center is this really pale pink appearance. You can think of how balloons look when you blow them all the way up. They're just getting paler and paler. And that's the same thing that's going on in these nuclei. So herpes inclusions have that characteristic appearance, and they also have the characteristic appearance that you're already noting as you look at this, which is that they have multiple affected nuclei kind of aggregated together. That is going to help you when you look at things on histopathology. So the difference between cytology and histopathology is cytology, you're just taking a liquid sample and sort of smearing it or spreading it in other manners across a slide. So you're seeing the entire cell kind of squashed down maybe. But in histopathology, you're actually taking slices of solid tissue, kind of like you take a bread slice out of a loaf. So you're actually seeing a cross section. So you can see some differences here from what you'd see on the cytology pap smear to what you'd see on the pathology biopsy, but you can still see some things in common. This multinucleation is key. The other thing is, of course, you still retain that cleared out nuclear chromatin. So all of these cells are actually infected with herpes simplex virus. There are other features that can help you know what you are dealing with. So herpes simplex virus, in this case, it's not too problematic because what you're seeing are these, again, multinucleated inclusions, and they all have, again, that sort of glassy, optically clearing nuclei. Now, if you don't think those are glassy, by the way, it's okay. I didn't either when I first started. I kind of came around to that gradually, but I will be the first to acknowledge that it is not readily something that comes to mind. But these herpes simplex inclusions, they're very classic. What's going on next to it? What you see here are mixed inflammatory cells. And over here where you see that the nuclei are getting smaller and smaller, this is actually debris. This is where nuclei are kind of falling apart because there is there's a degradation that's going. This is all just debris as everything's getting necrotic. So this is actually an ulcer associated with HSV. So you can see that there is a characteristic thick inflammatory infiltrate along with this herpes simplex virus. Here's another classic thing that associates with what you might see in HSV. Here you have an intact epithelium on top. You can actually even see the basket weave keratin on top. But underneath it, there's a space. And in this space are these HSV inclusions, right? These herpes inclusions. Now, what do you think that this would correlate to clinically if you had an intact epithelial roof, but underneath it is kind of a little space? That would be like a blister or a vacuole, right? So when you think about the vesicles that can form in association with herpes, this is the pathologic representation of that. Again, a roof of epithelium, but underneath it, kind of this space with all these viral inclusions. Incidentally, take a look at how these are herpes simplex viral inclusions, but so are these, so are these, so are these. This entire image is just chock-a-block full of herpes simplex inclusions. So let's talk about who would get herpes simplex virus infections. Of course, there are many infectious circumstances for which HSV is responsible for, but we'll talk about just the most common ones that we would encounter. In pediatric patients, you might see HSV type 1 as a stomatitis. So a lot of breakouts around the mouth. So those cold sores, it can be actually fairly widespread around the mouth in these pediatric patients. They can get it on their oral mucosa and their gingiva, so it can be very painful. Now, of course, HSV2 can be associated with genital infection in adults, and that can be recurrent. In pregnant patients, it can be a concern if there's active viral infection at the time of delivery. Those infants can acquire it through passage through the birth canal. HSV can also lead to visceral involvement, very severe visceral infections in patients who are immunosuppressed. So in a patient who is immunosuppressed, maybe they could have a herpes esophagitis, for example. That is something to keep in mind. Again, there are so many infections that it can cause a meningitis, encephalitis, conjunctivitis. So this is all possible with HSV. A recurrent dermatomal eruption. We think about that with zoster, right, with varicella, but it can happen with HSV as well. So especially in elderly patients, when you get a dermatomal distribution, it can actually be HSV as well. So a classic question might be, a 4-year-old male is brought to clinic for sores around his mouth. He's had difficulty eating because of those sores in his oral cavity. There is a similar lesion seen on his right index finger. So what can happen is as a child or an adult for that matter is sort of touching those areas that are affected, especially if there's already a small break in the skin on that finger, there can be a secondary involvement of the finger that can be called herpetic whitlow. So if you hear that term, that is what I'm referring to here in this sort of pseudo question. And then biopsy shows the findings in the attached image. So again, this is a gingivostomatitis in a pediatric patient. He's got a herpetic whitlow on his finger, and this is the pathology, herpes simplex virus. Oh, I also want to mention that typically you would want to see a preparation like this pap smear to identify those herpes viral inclusions. Um, Now, they're not really done that much anymore, but it's possible that you might see an image that is kind of the black and white version of this, and that might be a Zank smear, Tzanck. And really, it's going to show you, if you can imagine, this exact same image, um, just kind of decolorized, but that would be herpes simplex virus on a Zank smear. So here is cytomegalovirus, and cytomegalovirus is actually in the herpes viridae family. So what do you see when you look at this image? One thing that really pops out to you is that in this sort of background of mixed inflammatory cells and red blood cells, you're seeing these big guys, right? And of course, cytomegalovirus gets its name because cyto, cell, megalo, big virus. So big cell virus, right? So this is CMV. This is also CMV, and this shows you kind of the classic inclusions you get with CMV, and we'll talk about that in just a moment. Now, one thing about these cells, and you don't see images like this very often, is that it's not just the nucleus that's affected, it's actually the cytoplasm as well. If you go back and you look at the cells that were affected, they're popping out not just because the nucleus is affected, it's because the cytoplasm is affected. See, that's why these cells were so easy to identify, because everything about them is huge. Big nucleus, big cytoplasm. And this is why, because we have not only the nuclear viral factory going on, expanding here and creating that inclusion, we also have all these viral proteins collecting in the cytoplasm. So that is very typical of CMV. Now, CMV is also sometimes called owl eye in terms of the nucleus, so I just put this image in there to help you out. And the reason why we like to compare those inclusions to eyes is because these are Cowdrey A inclusions, and I'm going to talk about that in just a bit. First, let's talk about who gets CMV. And again, kind of like HSV, there are a lot of circumstances where you might see CMV. So one of those circumstances might be a lot of us. Mononucleosis is classically associated with Epstein-Barr virus, but primary infection with cytomegalovirus can give you a mono-like illness, and not all of us really get tested for what virus is causing it. So fully about 20% of us, by the time we reach adulthood, have had a primary CMV infection. Um, Newborns, one of the dangerous things about CMV is if you're pregnant and you've never had CMV and you get a primary infection with CMV at the time that you're pregnant, and that developing fetus is exposed to cytomegalovirus without pre-existing maternal antibody protection, that can lead to a very serious condition of congenital CMV, and that can lead to birth defects, deafness. Uh, it can have neurocognitive consequences. Perinatal CMV can happen. It's usually very subclinical and extremely mild. Immunosuppressed patients. That's going to be a theme because, of course, anytime an immunosuppressive situation is occurring, these viral infections can definitely be very dramatic, very widespread. So here's a classic example of a question that you might see with CMV. An 18-year-old female is status post bilateral lung transplantation for cystic fibrosis. A week after her transplant, she develops increased difficulty breathing and she has bilateral infiltrates on chest x-ray. A lung biopsy, and this is lung, this is actually the alveolus, shows these findings. So this would be a classic cytomegalovirus pulmonary infection in a post-transplant immunosuppressed patient. So I said I would talk about Cowdrey A and Cowdrey B. I've never really cared for these terms, but you might see them, so I'll explain what they are. Cowdrey A, like cytomegalovirus is the classic example, you actually have a little space between the inclusion and the nuclear membrane. So you can kind of see a little bit of a ring around the inclusion before you actually see the nuclear membrane. In Cowdrey B, the inclusion goes all the way to the nuclear membrane. So that's the difference between these two. And here's the illustration to kind of drive home that point. So in one of these illustrations, I've filled in a pupil. And if you think about it, again, this is why Cowdrey A inclusions are referred to as eyes because they look like a normal eye. In this one, there's kind of a spooky absence of the pupil, and that would be the CALGB. So if I asked you to do an eye illustration for me and you remembered that to be accurate you wanted to put in the pupil, I would give you an A plus. So that's a little mnemonic for how you can remember that these are the CALGB A inclusions. Before we move on, I will mention these are not wholly specific. That's part of the reason I don't particularly care for them, but again, you might see these nomenclatures used. Respiratory syncytial virus. We are not usually called upon to make this diagnosis morphologically because infants and small children with RSV are usually very recognizable and there are better tests. But I want to show you this image because this is a classic example of what you'd see in respiratory syncytial virus, and it speaks to the name respiratory syncytial virus. So in this lung tissue, you have a viral inclusion, and here it is. It's actually right there. And what it's done is associate itself with this multinucleated cell. Well, the way that happens is actually very interesting. Respiratory syncytial virus has a particular fusion protein, F protein, that will pull other cells to the infected cells and merge them together. And that, of course, allows for more replication. So basically, this infected cell has pulled and absorbed other cells, which is why now we have a multinucleated cell, a syncytium. So that is why you get respiratory syncytial virus as the name of this particular virus. Here's another really excellent example of that. So again, a multinucleated cell, and here is that really nice viral inclusion. That characteristic fusion is something you see in many paramyxoviridae. So those paramyxoviridae, besides RSV, include measles. So if you have a situation where you have a measles virus, it's going to look really similar. So who gets RSV? Well, of course, infants and young children with bronchiolitis. Even the adults can get it, but these are the infants that are particularly at risk. So a common example would be a 6-month-old male infant brought to the emergency department on Christmas Eve because of the seasonal nature of these RSV infections. And the baby's got labored breathing with retraction and grunting. When you listen to the lungs, there's bilateral wheezes and fine crackles. And then you can actually see this on a respiratory sample. This is not exactly the way most clinical medicine is going to work, but if you had a question like this and they showed you something like this, that would be RSV. Again, remember, that's why it's called syncytial. All right, moving along to papillomavirus, human papillomavirus. This pap smear shows you the classic haloing. It also shows you this little multinucleation here, all characteristic of HPV. The pap smear, if you think about it, was just so ideally suited to identify these cellular abnormalities, these pre-neoplastic conditions. So we're very lucky that we had that modality that was discovered to help us identify this particular viral infection. Here you can see the HPV inclusion on that pap smear again, translating to how it would look like on a biopsy. Again, a little bit different because on that biopsy, we're slicing through that tissue. But what we can still see is kind of a clear space around these weird nuclei, these kind of, looks almost bilobed there, right? And this is a pattern of dysplasia that you see in association with HPV. So this is, again, the histopathology and the cytopathology correlating with each other. So human papillomavirus. I'm just kind of talking about how to recognize it if you see it on an image, because this is a topic you need to know about pretty backwards and forwards. Human papillomavirus, the serotypes that are associated with cervical cancer, the various degrees of dysplasia. This is a topic that you need to know kind of backwards and forwards. And it's very important for primary care. Now, reproductive age women on pap smears, that will be classic for HPV. Anyone with a condylomatous lesion. Squamous cancers of the head and neck can be associated with human papillomavirus as well. So it's certainly something that you can see in various areas. Classically, a 21-year-old woman presents for annual physical, and her pap smear shows these findings. Human papillomavirus. Polyomavirus. Polyomavirus, particularly the BK virus, is important to be able to recognize because you can see it on urine samples from patients who've had renal transplants. What would happen is these cells would be identified, and here's a little bit higher magnification. They're actually kind of concerning for a malignant process. These kind of mimic malignant cells in urine. So they were dubbed decoy cells because they're not actually cancer, they're actually a viral infection. So in here, and you can maybe you're starting to be able to see this, but you have a little bit of clearing of that cytoplasm, so things are kind of going towards the edges here. And this is all viral infected, kind of pushing that chromatin aside. Here's a nice inclusion from the renal tubule. So this is actually a renal tubule showing a BK polyomavirus infection, an inclusion. And if you did a stain for BK virus, you'd identify it through this dark brown staining. So again, who gets polyomavirus? Renal transplant patients. So a classic description would be a 49-year-old female patient with a renal transplant 3 months ago, presents with hematuria and an elevated serum creatinine. Urine cytology shows this finding. This is important because if we see this, we might realize that the patient needs a lower dose of immunosuppressive so that the body can naturally fight off this polyomavirus, or putting them on an antiviral that might be effective against polyomavirus. This is why recognizing it is so important. One of my favorites is Parvovirus. Parvovirus inclusions are identified within this particular cell, and I'll talk about what cell this is in a moment, but you can see that it's actually got a dot-like inclusion in this nucleus. So it's not being that greedy. It's kind of forming a nice big inclusion, but not taking up the whole nucleus. Take a look at the cytoplasm. Think about what color you'd call that. That's a pretty dark blue. So when you think about what cell has a dark blue cytoplasm, you might have already cottoned on to this is an erythroid precursor. There is a predilection for parvovirus to go into erythroid precursors because they are specifically tuned to the P antigen receptor on erythroid cells. So what happens is these erythroid lineage cells get affected preferentially, and you can see that. You can see these viral inclusions within these erythroid cells. So you can actually see one down here as well. So this is classic for parvovirus. What do you think would happen then? Of course, you could get an anemia. Truthfully, if you or I had parvovirus, we probably wouldn't have a significant enough anemia. We'd probably recover and not really even have that much of a transient anemia, but it can definitely affect certain groups pretty profoundly. So one instance is hydrops fetalis. So in hydrops fetalis, we're more used to thinking about this in terms of hemolytic disease of the newborn, where there's an incompatibility between mom and baby, and the mom has antibodies attacking fetal red cells. Well, in parvovirus infection, what you're having occur is that developing fetus is infected with parvovirus and is profoundly anemic as a result. Once that anemia is severe enough, that developing fetus will have high output cardiac failure, and that will lead to fetal hydrops. In this sense, it's a very similar mechanism as the immune hemolytic disease of the newborn, but this is a non-immune hydrops. This is just basically the baby has an infection that's causing it to be very, very anemic. So when you have a hydropic infant and you think about parvovirus, what you can do is you can actually test placental tissue. So you can actually see that, without having to poke and prod the baby or do a bone marrow biopsy on the baby, you can look at the placenta and you can actually identify potentially these viral inclusions. And in this image, it would be hard to say that's definitely parvovirus, but this confirmatory immunohistochemical stain for parvovirus helps us know that that is the virus in question. So parvovirus, Again, who gets it? Primarily it's a very big issue in sickle cell patients. They get these aplastic crises where a parvovirus infection can set in, and because they already are compromised by their underlying chronic hemolytic anemia, you affect the source, and boy, all of a sudden they have a pretty bad anemic crisis. Persons with HIV infection, again, same thing. Immunosuppressed patients do not handle viral infections very well. Newborns with fetal hydrops, we already talked about. So let's look at this question. An HIV positive 43-year-old man has reticulocytopenic anemia. A bone marrow biopsy is performed and shows what you see here, that characteristic parvovirus inclusion in an erythroid cell. Now, why did I say reticulocytopenic? You might see that term tossed around. What that means is that someone's anemic, and if they're anemic and they're also low on the reticulocytes, it means it's a production issue. So the bone marrow is not turning out these reticulocytes, so the problem is at the source, at the production source. It's not a matter of peripheral hemolysis. There's a source issue. Pox virus. So take a look at this image. I kind of like this image. This is actually one of the prettiest things under glass. This is something called molluscum contagiosum. And so what you see clinically are these skin breakouts. It might be prettier under glass, I guess, but these raised kind of, they call them pearly lesions. You can kind of see that, very shiny. And in the center, you kind of have a little pale area, and that corresponds to sort of the cup shaped area that is holding all these viral inclusions. And so in this first image, I kind of showed this. These are actually sixlets. I'm not trying to ruin sixlets for you, but these little balls of pink that just fill up these cups. And of course, they're starting down here in the keratinocytes and moving their way upwards. But it almost looks to me like there was a cup here and someone just filled it up with little pink balls. And to be honest, I just think it's a very pretty image. So molluscum contagiosum, this is a pox virus. So who gets it? Children, adolescents. Anytime there's an abrasion on the skin, people talk about sharing towels, like at the pool or something like that, so they can pass around these skin inoculations. Genital lesions in adults can also be a form of molluscum as well. And of course, recurrent molluscum in HIV-infected persons again. So here would be a classic scenario: a 39-year-old female patient with small, painless bumps on her perineum. Inspection shows raised lesions, maybe it would say pearly lesions with pale punctate central areas. A biopsy shows the findings in this image. That would be molluscum contagiosum, caused by pox virus. So we've gone through all of these viruses and how to diagnose them on pathology. So I hope that talking through some of these morphologic features has helped you to be able to recognize them should you see them again. Again, always thank you so much for watching Pathology Scuba. Feel free to share these videos around, and if you've got any ideas that you would like to see included on future sessions, I've got my email address right there. I do love pathology, and I hope that you do too.